So hi, thank you. I'm going to try to stick in the excellent motive this morning and stay very practical. First, a disclosure. Actually, Friday was my last day to change it. Mortar knows as other people do. I recently moved on. Because I'm taking 4 months off, I'm not announcing where I'm going yet until after the holidays, so I'm going to go fishing and rock climbing for 4 months. But before I do, I wanted to make sure I had a chance to give this talk. And I'm also continuing with a lot of the volunteer work, in particular the One Mind for Research Foundation. I'm going to use a little bit of the application of that nonprofit to talk about informatics and personalized medicine, as well as what the excellent work that folks continue to do at J&J. So, we talked this morning, and Morgan gave an excellent talk about, kind of how we've seen things go on in the modern era. I was fascinated. I recently was asked to write a review paper on informatics and personalized medicine, and I ended up looking at the 1910s and what allergists did when they first started trying to figure out specifically what a patient was allergic to and how they could test that, understand that, and figure that out. But I think this is really important because I'm a late-stage cancer survivor. I always approach things from the standpoint of the patient. And I drive up my place in the Poconos, and I see every hospital saying they're doing personalized medicine. And I think they'd love to. I think we all would, but I think there's some work to do first. And my co-author on this, who is a clinician, and this was his quote, I wouldn't get in trouble for saying this, basically said that a lot of folks know that about half the time, especially in complex diseases, what they're going to prescribe is going to work. Not only that, but it actually is very much a trial and error process when it doesn't. And I see this in renal cancer all the time, where the patient does well on a targeted therapy, move them to another one. If they start to go back, then they start to do the combinations. And really what you get are wasted time and money sometimes, poor patient compliance. Sometimes the worst case is actually decreased alternatives for that patient because if they, depending on what type of trial they can get onto, let's take a cancer patient for a while, their first line of therapy may dictate what trial they can get on in second. And then obviously what was brought up around adverse events. So I think there's actually a lot we need to do better and to bring more knowledge into the action. This is a bit of an eye chart, I know, but what I wanted to do is talk, as an informaticist, I actually help myself understand what I do because I'm a rock climber. I go look at a rock face, and a really more experienced climber knows exactly how they're going to go up that face. All just looks like a flat place that I'm going to fall from to me. But they have a plan. They see it. They see the footholds. They see the handholds, and now they're going to go up. Well, in informatics, I think of use cases. What's the actual questions that are being asked and why? So, if we're looking for, is it risk of disease? Are we trying to determine who might get a disease? Early detection of a disease? Say you're talking about cancer. Are we subtyping a disease? Just the last speak, are we looking for biomarkers or diagnostics that help us understand the efficacy of a certain treatment in a disease case? We're looking for safety, pharmacogenetic markers, as we just said, and then targeted therapies for efficacy of disease subtypes and efficacy of mutated targets. And my talk will be out there, but we put some recent examples of these out there so people kind of see these cases coming through. So that's an idea. So each of these represents a different set of inquiry, a different path up the rock to an informaticist that's looking at all the data, as well as designing a study. So I did put a teeny little bit of economics, or at least economic thinking into this when we wrote this. And I think what people think of as you go to the right of this, as you get to personalized medicine, you're subsetting your market into smaller markets. That's okay. I would also agree with our colleague from Merck that J&J is very willing to do that. You find the right drug for the right patient at the right time at the right cost. That may drive up the cost per patient, but if it's a large unmet medical need, still very much worth it. Cost of society may go up. We see this all the time. I think the example that I like to use when people say, won't personalized medicine be extremely expensive?